Thank you, and thank the committee for the privilege of the podium. The topic is whether the endovascular management of ruptured aneurysms should become the standard of care, and obviously this is a debate that's going to go on. These are my disclosures. So the rationale for this, going way back, is the high morbidity and mortality, sometimes in excess of 50% for open repair, clearly left lots of room for improvement. And this was a concept that Dr. Veith, who you just heard mentioned, and the group at Montefiore had since 1993, which was the year they started doing endografts there and predates my arrival. That was limited at Montefiore and other centers, number one, by the time required to get a scan and measure for a graft, number two, for the ability to actually procure a graft, and number three, to the need to get rapid proximal control in cases of rupture. So there were many developments and early lessons that have occurred over time. This applies to all the studies that I will cite here, and some of them actually apply and benefit the open repair as well. One is the concept of hypotensive hemostasis. The second is of balloon control, which can be either obtained by a brachial or femoral access. The development of protocols and a team-based approach, which goes just even beyond the OR team, so the pre-hospital team as well as the post-operative care. The need for off-the-shelf solutions for endografts, which in the beginning was homemade grafts. That was the Montefiore endograft system. And then in later years, maintaining a shelf stock of industry-made grafts, and the ability to either get balloon control or do the entire procedure under local anesthesia. So there are several studies which have suggested that there's a significant advantage in Ivar over an open repair for AAA. I'll show you a couple of those, and then we'll talk about some randomized trials. Here's one showing a clear survival advantage. This is done in the Medicare population of over 40,000 patients, and the perioperative survival advantage of ruptured aneurysm, which can be seen right around the time of the procedure, endovascular, is maintained over the long term up to 4 years. Here's another study. This is 10,000 Medicare beneficiaries. And again, you see this survival benefit that goes out over 4 years. The authors of this paper also found there were fewer complications and a shorter length of stay in the endovascular group. And all of this occurred, if you look on the right, during a time when the number of open repairs was decreasing, endovascular repairs was increasing. The mortality for open repairs was essentially staying the same, but there was improvement in the 30-day mortality as experience was gained in the endovascular group. Now, there are a couple of studies that have looked at meta-analyses. This looks kind of busy, but the only thing to focus on is here in this forest plot showing that in the majority of these studies, there is a survival advantage in the endovascular group. And these total meta-analyses, I think there's about 60,000 patients in this whole group. This is another recent article from the European Journal. Again, same forest plot, and these groups divided these studies into about 40, whittle it down to 40 well-controlled studies. There are randomized trials seen here, observational studies here, administrative studies here. When they looked at this data, the risk of bias obviously is quite low in the randomized trials, but much higher in the observational and administrative studies. But you can see, again, in the vast majority of these studies, a significant advantage for the endovascular repair. Now, what about the randomized trials? So there are 3 very large trials, the AJAX, the ECAR, and the IMPROVE. They occurred beginning from 2004, running up through 2013, just under 1,000 patients and just under 50 centers. And you can see that none of these studies demonstrated a significant advantage for endovascular repair, similar to what you heard just previously from Dr. Hahn. The Cochrane group did a analysis of this, and they came to the same conclusion that there's no clear evidence to support a difference between the 2 interventions in 30-day or in-hospital mortality with a moderate level quality of evidence. But as they go back and look, the IMPROVE group has gone back and looked at their 3-year results and actually found that there was a midterm survival advantage, which when coupled with early gains in quality of life led to significantly higher QALYs. In the same group of patients, which was achieved without an excess of re-interventions and further hospital costs, shown here in these 2 graphs for survival and quality of life on the right. And a more recent study that is now in press Real-world experience also demonstrating superiority of endovascular repair. This was a study that was based on the Premier Healthcare database. This is a database that covers a number of different types of hospitals across the entire United States, so it's not biased towards any one model. So a couple of other just concepts. So what about Ivar suitability? That's always given an argument. So I can tell you that studies have found this case to be both ways. So here's a study from the European Journal again, that anatomical suitability for Ivar is not associated with lower early and midterm mortality in patients treated with open ruptured AAA repair. So you can't use that argument to say that the endo is better. And then here's another study from the British Journal that endovascular suitability was an independent and strongly positive predictor of survival after open repair of ruptured abdominal aortic aneurysm, so we can draw our own conclusions about that. Well, what about volume, or really experience? And we'll use volume as one measure of that. So here's a study from Dr. McKinsey from the Journal of Vascular Surgery. And in this panel here on the left, you can see that with increasing annual surgeon open volume, endovascular volume, and rupture experience, mortality improves. And the same is true for hospital. As hospitals do more open, endovascular, and rupture volume, outcomes improve. And the impact on teaching hospitals, here are two studies. One here showing that endovascular AAA is associated with improved mortality and outcomes compared with open repair, but in non-teaching centers, the results were substantially worse. And again, in-hospital survival from ruptured aneurysm, the lowest mortality was seen in teaching hospital. I think this is really a reflection of access to and experience with these grafts. So there's a couple of things to take into account post-procedurally. Number two, what about type 2 endo leaks? The bottom line is that if you look at most of these studies, that type 2 endo leaks, they're common after ruptured AAA repair and appear to be associated with a benign history, and the authors recommend a conservative approach to treatment. And again, looking out at the improved longer-term data, they did find a significant number of reinterventions after endovascular repair, double what occurs in elective repairs, but that amputations, even with most of those being limb occlusions, are less common than in those treated with open repair. Well, what are some of the other factors that might affect our willingness to move towards a gold standard? Well, one is the endograft technology continues to improve. So off-the-shelf branch grafts are becoming common, and as you've heard here, visceral chimney grafts and other off-label solutions are being increasingly utilized to temporize these patients. Well, what about training in open surgery? So here's a study from a couple of years ago where an initial prediction in a 2014 report was that vascular trainees would complete 5 open aneurysm repairs by 2020, but when they went back and looked at branched and FEVARs, the authors supposed that most trainees would complete only 1 to 3 open repairs during their training. And finally, the aneurysm epidemiology. So after the introduction of Ivar, there has been both a decreased ruptured AAA diagnosis and repair volume, as shown in the graph here, and an article last year of Journal of Cardiovascular Surgery shows that changes in the management of epidemiology, in the management and epidemiology, 1, the introduction of endovascular repair, 2, population screening, and 3, a decreased prevalence of the disease, all are going to lead to less experience. So, in conclusion, should Ivar become, for ruptured AAA, become the standard? I think probably that it should. The question is going to be when. It's not at present, at least as per the randomized controlled trials. Ivar techniques and experience will continue to evolve, and the concern is that open repair will actually become a lost art. We should also remember that Ivar may not be the end of the evolutionary tree in the solution of ruptured aneurysms. Thank you.